discovered to our surprise that we had outlier status, the bad outlier status for urinary tract infection at one point as we studied the semi-annual report. And the rate was around 3% or so, and it should have been about half that amount. And so the numbers weren't very large, but still it was significantly different than our comparable institutions based on the risk factors of the patients that we were treating. And so that set in motion a quality improvement project where we engaged our surgeons, nurses, quality improvement specialists, some consultants from urology and other services who helped us define the care pathway for our patients. And we realized that having Foley catheters was one of the main factors that was associated with infection in our patients, and we changed the way we managed those Foley catheters. And it was gratifying to see that that project then resulted in a decrease in the raw data and the risk-adjusted data for urinary tract infection. And we wouldn't have noticed that project or that problem in our own hospital if we hadn't had the SAR and the risk-adjusted data. Because when a rate of complication is in the range of 2 or 3%, you don't really know if it's acceptable or not unless you have good comparable data. It took about a year. It took about 6 months or so to get the team organized and get a care pathway established and get it implemented. And then within a couple of additional reporting cycles, we began to see that rate come down almost immediately, but it took probably a year before we got into the acceptable range. So it's not something that happens immediately. It takes a little bit of time to get a project off the ground, implemented, and then to see the results. We are in an area of the country that has a very large geographic area that we serve, and we knew that we had a little longer length of stay for colorectal surgery patients than many places around the country were reporting. But we assumed it was related just to the distances that the patients were traveling. And it was very useful to see that the data in the SAR pointed out that when one adjusted the risk of the patients, we were an outlier for length of stay when you took into account all the factors that you could think of in terms of why a patient would stay longer. So we mounted a new clinical pathway for patients undergoing elective colorectal surgery and have seen a very prompt decrease in the length of stay by instituting a care pathway that anticipated the needs of patients coming from long distances and had alternate strategies for them rather than just staying in the hospital a few extra days.